Welcome to this next video in which we are discussing sarcoidosis. Okay, so in the first video we saw how sarcoidosis is a systemic granulomatous disease in which you're going to get these granulomas forming in many different tissues around the body. In this next video, what I want to address is where are the common tissues for these granulomas to form. Now in sarcoidosis you can get granulomas forming pretty much anywhere in the body. However, there are certain places where you nearly always find granulomas in anyone who has sarcoidosis, and other places where it's very rare to find granulomas. So what I'm going to discuss here is where are the major sites where granulomas can form in sarcoidosis, and we're going to begin with the absolutely major sites where they form, which is in the lungs and the mediastinal lymph nodes. So this is known as pulmonary sarcoidosis, or we can call it pulmonary involvement. Okay, so allow me now just to draw a picture of the lungs and the mediastinal lymph nodes, and then we'll discuss what the symptoms are going to be then of granulomas forming in the lung parenchyma and the mediastinal lymph nodes. Excuse me. Okay, so I'll now begin my picture of the lungs and mediastinal lymph nodes. So here is the trachea, here, and of course the trachea comes down and will then bifurcate into the right bronchus, which will enter the right lung, and then the left bronchus, which will enter the left lung. So just to make sure that everyone is oriented, we are looking at someone from the front, so this is their right hand side and this is their left hand side. So I'll start off by drawing the right lung here, like so, and then remember the left lung is asymmetric to the right lung. It's not the mirror image of the right lung, because there is this notch here called the cardiac notch, which leaves this space where the heart is going to sit. Okay, so there's our left lung, and here is the space where the heart would sit. Okay, so here's a basic picture of the lungs and the trachea and the two major bronchi entering each of the lungs. Okay, so let's start with the granulomas which are actually going to form in the lung parenchyma then. So in sarcoidosis, 95% of people suffering from sarcoidosis are going to have pulmonary sarcoidosis, i.e. they're going to have pulmonary involvement. And one of the major places as part of pulmonary involvement where the granulomas will form is in the actual lung parenchyma itself, the lung tissue. So you're going to get granulomas forming all over the place in your lungs, like so. So each of these is a granuloma that I'm now drawing, and you'll get them in both of the lungs. So I'll colour each of these granulomas in orange here, so you've got lots of granulomas forming in the tissue of the lungs. Now let's think about what the symptoms of these granulomas forming in the lung tissue are actually going to be. So when you've got something inside the lungs that shouldn't be there, what is the body's response to that? Well, it is to cough. So one of the symptoms that you're going to get from having these granulomas forming in the lung tissue is going to be that you're going to get a persistent cough. So coughing is going to be one of the major symptoms of pulmonary sarcoidosis. In addition, if this gets quite bad and you've got a huge amount of lung tissue having been replaced by granulomatous tissue, then it's actually going to start affecting the function of the lungs. Now remember, what is the function of the lungs? The function of the lungs is to bring in fresh air from the environment and allow the oxygen from that fresh air to go into the blood, and allow the carbon dioxide from the blood to go into the air. So the major function of the lungs is gas exchange. Now, if you've got a huge amount of lung tissue replaced by these granulomas are not going to be participating in gas exchange. So you're losing lung tissue that's actually going to be participating in gas exchange. So you can start to get symptoms that are due to gas exchange being reduced. So for instance, shortness of breath will be one of the symptoms of sarcoidosis once it gets to a certain stage. So shortness of breath, which which means that you are struggling to get enough air into your lungs to actually get adequate gas exchange. So you feel like you're not breathing in enough fresh air. So you'll be panting and things like that. Okay, so shortness of breath is another major symptom of pulmonary sarcoidosis. So that's only half of what we mean by pulmonary sarcoidosis. So granulomas actually forming in the lung tissue itself is half of pulmonary involvement in sarcoidosis. The other major place that granulomas can form that goes hand in hand with them forming in the actual lung tissue is they can form in the mediastinal lymph nodes. So let me just draw on a few mediastinal lymph nodes here. So all tissues in the body have lymphatic drainage, and lymphatic vessels drain into lymph nodes, and the lymphatic drainage from the lungs is going to drain into lymph nodes that are in the mediastinum, which is this space in between the two lungs here. And these lymph nodes in the mediastinum are known as the mediastinal lymph nodes, and I'm drawing some of them on as these green dots here. So there are two major groups of mediastinal lymph nodes. The hilar mediastinal lymph nodes, which are these ones that are at the hilar of the lungs. So remember, the hilar of the lungs are where the major bronchi enter the lungs. So we've got here the right bronchus entering the right lung. That point where it enters the right lung is known as the hilum of the right lung, and I'll just write that keyword down. And similarly on the left-hand side, the point where the left major bronchus enters the left lung is known as the left hilum. Okay, so those lymph nodes that are very close to the hilar, which is the plural for hilum, these ones here around the major bronchi, these are known as the hilar lymph nodes. Okay, and they are part of the mediastinal lymph nodes, because of course they are in the mediastinum, so these are within the group that we call mediastinal lymph nodes. Okay, there is then another major group of mediastinal lymph nodes, which are the ones that you can see that surround the trachea here that I've drawn on as green dots as well. Those are known as the paratracheal lymph nodes. So we have these two major groups of mediastinal lymph nodes, the hilar lymph nodes and the and the paratracheal lymph nodes. Now, in pulmonary sarcoidosis, the hilar lymph nodes, but also the paratracheal lymph nodes, so overall we can say the mediastinal lymph nodes, are generally going to get granulomas forming in them. Okay, and when a granuloma forms inside a lymph node, what that's going to cause is it's going to cause swelling of the lymph node. So the lymph node is going to swell to a much bigger size. And this doesn't cause any symptoms, but it does give rise to a sign that is visible if you take a chest x-ray of someone with pulmonary sarcoidosis. And that sign is known as bilateral hilar lymphadenopathy. So I'll put this here. So you wouldn't get any symptoms from this. A person with sarcoidosis would certainly not go to their doctor saying that they have bilateral hilar lymphadenopathy. They would go saying they have a cough and they're short of breath. But when they're put in an x-ray machine and we take an radiograph of the chest, then we can see the enlargement of these lymph nodes at the hilar of the lungs, and this is known as bilateral hilar lymphadenopathy. So bilateral means that it affects both sides of the body. Hilar refers to the hilar lymph nodes, and lymphadenopathy refers to some pathological process of the lymph nodes. Lymphadeno means lymph nodes, and then pathy means disease. Okay, so we say that one of the common signs of pulmonary sarcoidosis then is bilateral hilar lymphadenopathy. Okay, so that's the major site where sarcoidosis affects. You get granulomas forming in the actual lung tissue itself and also in these mediastinal lymph nodes, particularly in the hilar mediastinal lymph nodes. And as we say, 95% of people with sarcoidosis will have pulmonary involvement and will generally present with these symptoms of coughing and shortness of breath. And for this reason, people with sarcoidosis are generally actually managed by pulmonologists, which are doctors who specialise in the lungs and the respiratory system. Okay, so this is the major place which sarcoidosis affects then. Okay, so now what we're going to discuss is other places that sarcoidosis can affect. These are less common than the pulmonary involvement. This is the archetypal place for the granulomas to form in sarcoidosis, in the lungs and the mediastinal lymph nodes. So, the next place that I want to discuss is that these granulomas can affect the skin. So I now want to talk about cutaneous involvement in sarcoidosis. So we can call this either cutaneous involvement or we can call it cutaneous sarcoidosis. Okay, so cutaneous sarcoidosis affects a smaller proportion of the people with sarcoidosis than pulmonary sarcoidosis. So about 25% of people with sarcoidosis will have cutaneous sarcoidosis. They'll have granulomas forming in the skin. Now, some people, rare cases of sarcoidosis, this might be the only place where the granulomas are going to form. They might not have any pulmonary involvement at all. So in rare cases, you can just get cutaneous sarcoidosis with no lung involvement. And of course, if that's the case, then the person would most likely be managed by a dermatologist rather than a pulmonologist, a doctor who specializes in the skin. Okay, so let me now draw a picture then of the skin with a granuloma in it. So firstly, let me just draw a little picture of healthy skin. So I'll remind you that the two major layers of the skin are the dermis and the epidermis. So here is a very basic picture of the skin. So this is the outer world here, and then the outer layer of the skin is what's known as the epidermis. And then underneath the epidermis, you then have the supporting layer, which is then known as the dermis. So it all makes sense because epi means surrounding or around. So the epidermis is around the dermis, it covers up the dermis. Okay, and you can see that there are these little sort of, the junction between the epidermis and the dermis is not smooth, it's not a straight line. Instead, there are these ridges that keep the epidermis and the dermis interlocked with one another. Okay, so here's a basic picture of the two layers of the skin, the dermis and the epidermis. So the question now arises, in cutaneous sarcoidosis, we're going to get granulomas forming in the skin. Which layer of the skin are they actually going to form in? Is it going to be the dermis or the epidermis? Well, the answer is that it's going to form in, they're going to form in the dermis. So let me now draw a picture of a granuloma in the dermis. Now we have the skin raised up like so, and here is the epidermis, okay, which isn't affected. The granuloma hasn't formed in the epidermis, so I'll colour this layer in orange here. It's just being distended in this way because of the granuloma forming in the dermis underneath. And then here, this is going to be where the granuloma has formed. So this is the bad guy. So I'll colour this in red. So here's the granuloma, which has formed in the dermis of the skin. So this is the dermis, and you can see that it's caused a distension of the skin. So you will get a visible raised portion of skin here that will appear very swollen and red. Okay, so a little bit of dermatological nomenclature now. When you have a raised portion of skin, you can either call that a papule or a nodule. Now, there is a definitional difference between a papule and a nodule, so we can either describe this as a papule or a nodule. Now, what is the difference? A papule is when the raised portion of skin here is diameter less than 1 centimeter. So if the size of this raised portion of skin is less than 1 centimeter, then we would refer to this skin lesion as a papule. Whereas if the size of it is greater than 1 centimeter, then we refer to it as a nodule. So depending on how big the granuloma that we formed in the dermis here actually is, then you would describe the skin lesion as either a papule or a nodule. So cutaneous sarcoidosis causes these papules and nodules to form over the body, which are these granulomas that have formed in the dermis layer of the skin. Okay, so next, as I say, let's just summarise this firstly. So this will occur in 25% of people who are suffering from sarcoidosis. They will get papules and nodules on their skin, which are where these granulomas have formed in their skin. Okay, so the next place that I want to discuss where sarcoidosis can affect is the eyes. So next up, let's discuss ocular sarcoidosis. So granulomas terrifyingly can affect the eyes. They can form in the eyes, and this actually is not too uncommon. This occurs in approximately 30% of cases of sarcoidosis. So 30% of people suffering from sarcoidosis will get some eye involvement. Now, the granulomas generally form in a portion of the eye known as the uvea. So firstly, what I want to address is what actually is meant by this word, the uvea, because it means a lot of different structures of the eye that you probably know by different names. Okay, so I'm just going to draw a basic picture then of the anatomy of the eye. So, to orient you, this is going to be the front here, so I'll just put the cornea there, and this is going to be the back, so we'll have the optic nerve coming off here, like so, and then I'll come round like so. Okay, so now I'll make this some thickness rather than having it just represented as a line. So of course this is the outer layer of the eye here, and it continues to surround the optic nerve. So it's the sclera and the cornea which are continuous with one another, like so. Okay, so I'll label this bit up firstly. So right at the front, this is of course the cornea. So this bit, which I'll colour in here in yellow, this is the cornea. And then behind all of this bit here, which colours the rest of the eye, this is what is known as the sclera, and this is the bit that appears white. So the cornea is obviously transparent, whereas the sclera is opaque, it appears white. And that's to do with the connective fibres that are in the cornea portion here all being aligned perfectly so that light can actually pass through, whereas in the sclera that isn't the case, so light can't pass through. So I'll colour the sclera here in orange. And as I say, it's continuous with a covering of the optic nerve behind here. Okay, so this is the outer layer then of the eye, the sclera here and the cornea at the front, and they're continuous with one another, but as I say, the major difference is that the cornea is transparent, whereas the sclera is opaque. Okay, now let's do the next layer of the eye. This is not the uvea. This outer layer of the eye is not the uvea. And of course, we're just taking a two-dimensional cross-section here. We're taking an axial cross-section, so a transverse plane through. This is the right eye here. We're imagining that we're looking from above and we're seeing the different structures of the eye. The next layer that is underneath this outer layer, which consists of the cornea and the sclera, this is what's going to be known as the uvea. So it consists of the iris right at the front. So now it's going to start actually looking more like an eye now that I've put the iris in here. So here's the iris, and then the iris is continuous back with more structures. So what you then have after the iris is the ciliary body, also known as the ciliaris muscle, and then continuous with that behind, you then have the choroid, like so. And the choroid doesn't go into the optic nerve. So all of this is the choroid here coming forward. Then we'll have the ciliary body here, and it's continuous with the iris there. So all of this layer, this is what is meant by the uvea. So the uvea means the iris muscle here, and let's imagine that they have blue eyes, so their iris is blue. Well, at least it appears blue from the front, but that can be a basis for me colouring it in blue. So this is the iris here, this is part of the uvea. Then behind the iris what we have is the ciliary body here. So this is the ciliary body here. And this is going to be secreting the aqueous humour, which fills the anterior and posterior chambers of the eye. And also it's going to be controlling the shape of the lens. So I'll label that up. That's another portion of the uvea. So all of this continuous layer here, the iris, the ciliary body, and then the choroid behind it, all of this is the uvea. So here's the ciliary body, which I'll colour in red, and then behind the ciliary body, here now in pink, this is the choroid, which is the layer underneath the retina. Okay, so there in pink, that's the choroid. Okay, so now to complete up my picture of the eye, let's put on the lens, okay, and then also the retina, of course. So the lens is suspended between the ciliary body, or in the middle of the ciliary body, and you have to understand this picture is just an axial cross-section. This is a transverse plane through the eye. The ciliary body, in fact, goes all the way around and forms a ring. So if I was to see this from the front, what it would look like is this. This is what the ciliary body would look like. It would be a ring structure like so, okay? All the way around, a muscle that goes all the way around. We have taken a cross-section like this, and we're just seeing this portion, which is here, and this portion, which is here, but it goes all the way around the eye, and therefore forms a ring of muscle and also glandular tissue that's going to be secreting the aqueous humour. But at the moment, since we're talking about the lens, we're particularly interested in the muscle component of the ciliary body, which is also called the ciliaris muscle. So the muscle component of the ciliary body is also called the ciliaris muscle. Okay, so suspended then from the ciliary body, you're going to have the lens, and it's suspended by little ligaments known as the suspensory ligaments, and then we'll have the lens sitting here. Okay, so this is the lens, and then these little structures that I've drawn on either side, those are representing the suspensory ligaments. And allow me also to just draw it over here, showing you it from the front rather than with this axial cross-section. Okay, so the suspensory ligaments will be going all the way around like so, forming a ring of suspensory ligaments, and then you'd have the lens right in the centre here. So if I just colour this in, here's the lens coloured in yellow, and we'll also colour it in yellow over here, like so. Okay, and you can see that the way the suspensory ligaments surround the lens as a ring like so, this gives rise to another name for this structure. So this ring here that's suspending the lens in between, or in the middle of the ciliaris muscle here, this is also known as the zonule of Zinn. Just another name. So I'm giving you rather a lot of background of the anatomy of the eye, but it's all worth it. So we will come back to sarcoidosis in just a moment after we finish the anatomy of the eye. Okay, so where are we then with the anatomy of the eye? So we've got the lens here. Oh, and to just tell the story of how the ciliary muscle controls the shape of the lens. So the ciliary muscle, it's this ring of muscle here, and it can constrict. So when the muscle cells of the ciliary body contract, what's going to happen is that ring is going to constrict. And you can imagine that when it constricts, then the suspensory ligaments are going to become much more slack. So they're going to be pulling on the lens less. And therefore the lens can actually adopt a more globular shape. So it can go from looking like this to looking maybe a little bit more like this. Okay, so this is when the ciliary body contracts. The suspensory ligaments go slack, it can adopt a more globular shape. And this shaped lens will have a greater power. It will be able to focus light more powerfully. And this is what you're going to need to be able to look at objects that are closer to you, where the angle that the light is diverging away is greater. So just to draw a little picture of this, when you've got an object that's very far away, so let's say this is the eye here, okay, viewed from the side now, so this is the pupil here. So if you've got an object that's very far away and it's emitting light, then the light that's coming into your eye, you can see that the angle that that's going to be diverging away, the light that's coming from this one point here, the angle that that's going to be diverging away is quite small. and therefore you don't need a very powerful lens to focus all of this divergent light onto a single point. Whereas if you've got something that's much closer by, then you can see that the light that's going to be entering or the eye from this object, okay, so this is a object that's emitting light that's much closer to you, the light that's going to be coming from that object is going to be much more divergent. The angle between the light rays is going to be much greater, and therefore it's going to require a more powerful lens to focus all of that light coming from this single place onto a single place on the retina. And that's why you want to change the shape of the lens, to change the power of the lens, and to change whether you can focus objects that are near to you or far away from you. So to focus on objects near to you, you need a more globular lens, and therefore you need to contract the ciliary body, whereas to focus on light from objects that are further away from you, you need a more, less globular lens, a more flat lens, and therefore you need the ciliary body to relax, to stretch these zonules in and stretch the lens out into a flat shape. Okay, right, so that's enough physiology of the eyes. Let's now complete the anatomy of the eyes and then go back to sarcoidosis. So to complete the anatomy of the eye, we need to put on the essential layer, the retina, the layer where the actual photoreceptors are, and this is inside of the choroid. So here, this is the retina, and it continues on into the optic nerve, so it's continuous with tissue inside the optic nerve, because of course the retina consists not just of the photoreceptors but of all the nerve cells that are going to relay the information from the photoreceptors to the brain, and these are all going to be sending their axons into the optic nerve. So here is the retina like so, and again it's going into the optic nerve. So I'll colour this in. So we'll have this coloured in green, I think. So here is the retina continuous with this portion inside the optic nerve, and equivalently on this side like so. Okay, right, and you can see that finally in the optic nerve here, so this is cranial nerve 2, also known as the optic nerve, there is this space down the middle of the optic nerve, and this is where the arteries and veins that are going to go onto the surface of the retina are going to run. Okay, in that central canal of the optic nerve. Okay, so this layer here is the retina. The final thing that I want to point out for the anatomy of the eye is that there's a portion of the choroid that is not actually covered by retina. So this portion up here, you can see there's a portion of the choroid here not covered by retina. So the retina doesn't actually stretch all the way round, because there just isn't any point of having retina over here, because no light is actually going to get there. So this portion of the choroid that doesn't have any retina covering it is known as the pars plana portion of the choroid. Okay, actually, I've got one final thing to say about the anatomy of the eye, and this is to do with the chambers of the eye. So you can see that the eye is now separated into 3 separate chambers. There is this space here in front of the iris, but behind the cornea, and I should just point out that this space here is the pupil in the middle of the iris there. So there is this chamber here, bounded anteriorly by the cornea and bounded posteriorly by the iris here. That's known as the anterior chamber of the eye. So that's called the anterior chamber. The space behind that, so behind the iris but in front of the lens here, and of course is continuous with the anterior chamber via the pupil, that's known as the posterior chamber. So the anterior and posterior chamber are continuous with one another, and both of them are filled with aqueous humour, which is produced by the ciliary body. So aqueous humour is what fills these. So the ciliary body, as well as being a muscle, it's also a gland, and it's going to be secreting aqueous humour into the posterior chamber, and this is going to be going into the anterior chamber, and that's what fills these 2 spaces. Okay, so those are those 2 chambers. So the important thing to not get confused with is to not think that the anterior chamber is all of this space, i.e. This space then going through the pupil and this space here. Those are considered 2 different chambers, the anterior chamber and the posterior chamber. People often get confused and just call all of that the anterior chamber and then all of this the posterior chamber, but that's not the case. This big chamber here, bounded anteriorly by the lens and posteriorly by the retina here, this is what's known as the vitreous chamber. And this is full of vitreous humour rather than aqueous humour, which is much more viscous than aqueous humour. Vitreous humour is more like a jelly, whereas this is more like a syrup. So this is filled with vitreous humour. Okay, right, and I think that will do for our discussion of the anatomy of the eye. Let's now actually return to the topic of sarcoidosis. So, why did we go into this discussion of the anatomy of the eye? Because sarcoidosis can affect the uvea of the eye. Now, we've discussed what the uvea of the eye actually is. It's this middle layer of the eye. It's all of these different structures, the iris anteriorly, then the ciliary body after that, and then the choroid after that. All of those structures together, which form one layer of the wall of the eye, those are known as the uvea. And sarcoidosis can affect the uvea. You can get sarcoid granulomas forming in these different structures of the uvea, and this can lead to big problems. Okay, so this can lead to what's known as uveitis. So whenever you get immune cells coming into a portion of the uvea, we call that uveitis, inflammation of the uvea. Now, the formation of a granuloma is certainly bringing immune cells into the uvea, so we'd refer to it as an inflammation of the uvea. So sarcoidosis can cause uveitis then. And we can divide uveitis into 3 different types. There is anterior uveitis, there is intermediate uveitis, and then finally there is posterior uveitis. Okay, so let me discuss what these 3 different types are. So anterior uveitis, you can probably work this out for yourself. Anterior uveitis is uveitis that affects the anterior portion of the uvea. So the iris and the ciliary body, those are considered the anterior portions of the uvea. So if I got a granuloma forming in the ciliary body or in the iris, God forbid, that would be called anterior uveitis. And if it formed very anteriorly, so if it, for instance, formed in the iris, you would most likely be able to actually see that, and you'd be able to see a very red eye, for instance. Okay, so that's anterior uveitis. Intermediate uveitis is when it occurs in the pars planar region, this portion here. Okay, and this is sometimes also referred to as pars planitis. So pars planitis. So if you get a sarcoid granuloma forming in the pars planar region of the uvea, then that will be called intermediate uveitis or pars planitis. And then you'll be able to work out what posterior uveitis then is. Posterior uveitis is when it would form in the portion of the choroid that is covered by retina, and that you can imagine would lead to a lot of disturbance of the retina, which could then lead to, for instance, seeing things like flashing lights. Okay, so posterior uveitis would occur in the portion of the choroid underneath the retina. So what sort of symptoms can we have here? Anterior uveitis, as I say, you'd probably actually be able to see the lesion potentially, and you'd see a very red eye. All 3 of these would cause potentially blurred vision because they could affect the focusing of light onto the retina. So that would be a symptom of uveitis in general, blurred vision. As I say, anterior uveitis, you'd probably actually be able to see the lesion and you'd be able to see a very red eye. Intermediate uveitis, you'd get blurred vision. Posterior uveitis, you'd probably get blurred vision as well, but you might also get flashing lights. But you might also see flashing lights because of the disturbance that the inflammatory process is going to cause to the retina on top of it, and that might actually cause the retina to fire inappropriately so that you would see flashing lights. And when you see flashing lights, that is known as photopsia. Okay, the fancy word for seeing flashing lights is photopsia. And of course there are many other symptoms that can arise because of anterior, intermediate, and posterior uveitis. I'm just going over some of the very basic ones. Okay, so sarcoidosis then, in 30% of cases of sarcoidosis you can get ocular involvement, and this is going to involve granulomas forming in the uvea portion of the eye. Okay, so the final place then that I want to talk about where sarcoidosis can affect is the heart, and this is known as cardiac sarcoidosis. Now thankfully this is reasonably uncommon, so this is only going to affect 5% of people who are actually suffering from sarcoidosis, but the consequences can obviously be very severe. So cardiac sarcoidosis, so this is going to affect 5% of people with sarcoidosis. So let me just draw then a basic picture of the heart, and we'll discuss what the consequences of granulomas forming in the heart can actually be. So I'm going to start by drawing a picture that is very anatomically true. So it's going to be a picture from the front of what the heart looks like. And then what I'm going to draw is a cross-section picture so that we can actually look at the conduction network within the heart. And we can understand then how granulomas might actually affect this conduction network. Okay, so to begin with then, a anatomically true picture of the heart. So, I'll start with the right atrium then, up here. So here is the superior vena cava coming into the right atrium, and then we're going to have the right ventricle coming down here, then the left ventricle here. So I'll now draw the boundary of the right ventricle here. So this is the pulmonary trunk coming out of the right ventricle here, going up like so. Then I'll add on the aorta here. So this is the left ventricle over here, and the aorta, however, will come out over here from the back and will go up like so. Then we can add the pulmonary trunk splitting into the two pulmonary arteries. So this will be the right pulmonary artery and this will be the left pulmonary artery. And complete the right atrium up there. And then we'll have the left atrium up here, where we'll have the two left pulmonary veins coming into the left atrium here. And we'd also of course have the two right pulmonary veins coming into the left atrium as well, but they'd be behind all of this, so we can't actually see them on here. Okay, and then just to complete up the picture, we'll have the inferior vena cava here. So just to label this basic picture up, so this is the superior vena cava up here, the great vein that drains the superior portion of the body and will drain into the right atrium. This is the inferior vena cava here, the great vein from the inferior portion of the body. So I'll colour both of these in blue. And then they're draining into the right atrium, which is this great chamber of the heart here. And then the right atrium, the blood will drain into the right ventricle, from the right atrium into the right ventricle. Then we've got the pulmonary trunk coming out of the right ventricle, so this is the pulmonary trunk. And then the pulmonary trunk is bifurcating into the two pulmonary arteries. So here we have the left pulmonary artery, and here we have the right pulmonary artery. So these are pulmonary arteries. And of course the blood is still venous here, so I'll colour those in blue as well. The blood will go round the lungs, and then the blood will return to the heart from the lungs once it's oxygenated by the pulmonary veins, and there are two pulmonary veins coming from each lung. So these are the left pulmonary veins that we can see here, but there would also be two right pulmonary veins coming in on the opposite side. And they're coming into the left atrium here, and they're carrying oxygenated blood, so I'll just colour them in red there. And then from the left atrium the blood will go into the left ventricle here, and then the left ventricle will eject the blood into the aorta here. Okay, and of course that will be oxygenated blood as well, so I'll colour that blood vessel in red. Okay, so there's a basic picture of the anatomy of the heart. What I now want to do is take an unusual cross-section. Well, it's not an unusual cross-section as far as physiology is concerned. Physiologists take this cross-section all the time, but it's an unusual angle to actually make a cross-section at. But there is a good reason that we make this cross-section. So what we're going to do is we're going to imagine taking a plane through the heart like so, at this bizarre sort of oblique angle. So I'm going to put my knife in like so and cut through the heart. And the basis of taking a plane like this is so that we can actually see all of the different chambers. So we'll get a section of the right ventricle, a section of the left ventricle, a section of the right atrium, and a section of the left atrium. So if we actually were to cut open the heart here, we might see something like this. Okay, so we're going to have the right atrium up here, we're going to have the left atrium up here, and this is of course the wall of the heart, and this is the chamber, and then we'll have the right ventricle down here and the left ventricle down here. Okay, so I hope this is clear. So this is the right atrium, this is the left atrium, this is the right ventricle, and this is the left ventricle. So this is the cross section that we've taken of the heart, and it shows us all of the 4 chambers. So why am I doing all of this? Well, what I want to show you, what I want to remind you of, is the conduction system in the heart, because this is one of the major consequences of cardiac sarcoidosis. So cardiac sarcoidosis, hopefully it's pretty clear, you're going to get granulomas forming in the heart, in the muscle of the heart. What are the consequences of cardiac sarcoidosis? Well, it can affect the conduction system through the heart, and that can be extremely dangerous. That can lead to arrhythmias. It can also affect the power of the heart, which can lead to heart failure. So let me just remind you of the conduction system within the heart. So, remember, the electrical signal for the heart to beat, it originates in the sinoatrial node, which is up in the wall of the right atrium here. So in red here, this is representing the sinoatrial node, the SAN. So roughly every 0.8 seconds, the sinoatrial node will generate an electrical signal, and it will pass this electrical signal onto the atria. Okay? The electrical signal will then propagate down the walls of the atria, causing the atria to contract. Remember, the muscle cells of the atria cannot pass the electrical signals onto the muscle cells of the ventricles, because there is an electrical insulation between the atria and the ventricles. So there is a connective tissue band, a septum that separates the atrial muscle cells from the ventricular muscle cells, and this is known as the interventricular septum, and this insulates the atrial muscle cells from the ventricular muscle cells. So this is called the interventricular septum, and this, as I say, prevents the muscle cells of the 2 atria here passing the electrical signal onto the muscle cells of the ventricles. So this is the interventricular septum, and I'll just colour this in green. So, what this means is that the electrical signal that has propagated down the right atrium and the left atrium cannot just pass on straight to the right ventricle and the left ventricle. And the reason that you wouldn't want it to do that is because if it did just pass it straight onto the right ventricle and the left ventricle, you'd get contraction of the ventricles starting from the top and working its way downward. Now, if you can imagine what would then happen, you'd be pushing blood down into the bottom of the ventricles, and that's not what you want to do. You want to push blood up in the case of the ventricles. In the case of the atria, it was fine for the electrical signals to propagate down, because where were you pushing the blood out to? Well, you wanted to push the blood down into the ventricles. That was where the opening into the ventricles was, down. So therefore it was fine for the electrical signal to begin at the top and work down. In the case of the ventricles, that's not what you want. You want the blood to be pushed up and outwards, so you want the electrical signal to start at the bottom and work its way upwards, rather than starting at the top and working its way downwards. And that's why we have this electrical signal, this electrical insulation between the atria and the ventricles, to prevent the atria just passing the electrical signal straight onto the ventricles. So the sinoatrial node here, the SAN, and I'm just going to actually write out the name of the sinoatrial node in full. I feel like I should do that just once at least. So the sinoatrial node generates these electrical signals at a rate of roughly 1 every 0.8 seconds to give us overall a heart rate of around 75 per minute, so roughly 0.8 seconds. And these electrical signals will propagate down the atria, and then the one place where they can actually pass from the atria to the ventricles is through a small window in the interventricular septum, which is known as the atrioventricular node. So there is a hole in the interventricular septum where you have muscle cells passing through the interventricular septum, and this special cluster of muscle cells is known as the atrioventricular node, the AVN. So this is the atrioventricular node. Okay. Oh, and can I just apologise, this is not called the interventricular septum, this is called the atrioventricular septum. I was just thinking that doesn't actually make sense. Interventricular septum would be between the two ventricles. This is a septum in between the atria and the ventricles, so we would call this the atrioventricular septum. Okay, I apologise for that. Right, so the atrioventricular septum is this insulation between the atria and the ventricles, and the one window through the atrioventricular septum is the atrioventricular node, and these cells are going to pass the electrical signal from the atrial muscle cells to the ventricular muscle cells. Okay, now, where are they going to pass it on to? Well, they're going to pass it on to special muscle cells that are in the wall of the ventricles. This is the interventricular septum, this sheet of muscle in between the two ventricles. Okay, so they're going to pass it on to special cardiac muscle cells in this interventricular septum. So you have to understand that in the heart, you have two major different types of muscle cells. You have muscle cells that are for contraction, okay, and those are the simple ones that are just going to contract when they receive the electrical signal, and then you have ones that are specialized for conduction, and these are not very good at actually contracting, but they conduct the electrical signal much faster than normal cardiomyocytes do. Now, the cells of the sinoatrial node, these are specialized conduction cardiomyocytes. They are specialized, their purpose in the heart is with regards to the electrical signal, generating the electrical signal and then passing it on to the other cardiomyocytes, which are the contraction cardiomyocytes, which when they receive it will contract. Now, the atrioventricular node cardiomyocytes, they are also conduction cardiomyocytes. They are a specialized part of the conduction system within the heart. Their role is with regards to the propagation of the electrical signal rather than to actually contract. And now, in between the two ventricles, in the interventricular septum, you're going to have more of these specialized conduction cardiomyocytes. So let me now draw these on. So they pass it on to a string of cardiomyocytes that forms a bundle known as the bundle of His, which very quickly breaks into two parts, a right bundle branch and a left bundle branch, like so. Okay, so what are we seeing here? Initially, there is this band of specialized conduction cardiomyocytes, which is where the electrical signal is going to be passed on to first, known as the bundle of His here. Okay, so the electrical signal is going to propagate down the bundle of His, and the bundle of His is insulated from the surrounding contraction cardiomyocytes. Okay, so the electrical signal is not just going to be passed on to these surrounding contraction cardiomyocytes. Otherwise, we wouldn't have achieved anything, because now the electrical signal would just propagate from the top downwards. So it has to be insulated, and it's going to be conducted along this special conduction pathway made of these special cardiomyocytes, and this is known as the bundle of His. Then what happens is the bundle of His is going to split into two separate pathways, a right pathway and a left pathway. So the right pathway is known as the right bundle branch, and the left pathway is known as the left bundle branch. So we have these two bundle branches. So I'll just label up one, but you get the idea that this is the left bundle branch here. In fact, I'll just abbreviate it down to BB. There we go. Okay, and these two pathways are going to take the electrical signal down to the bottom of the ventricles, and then finally what's going to happen is the electrical signal is actually going to be unleashed on the normal contraction cardiomyocytes. Okay, and it's going to be unleashed by means of little fibers of conduction cardiomyocytes known as the Purkinje fibers. So off from these major bundle branches are going to come little pathways of conduction cardiomyocytes, so little fibers here, that are then going to be responsible for passing the signal on to the actual contraction cardiomyocytes. So these little fibers are known as the Purkinje fibers. Okay, right, and then the electrical signal will be passed on to the contraction cardiomyocytes, and then it will just propagate from contraction cardiomyocyte to contraction cardiomyocyte. And of course, when they receive the electrical signal, the contraction cardiomyocytes will contract. Okay, so to summarize the electrical conduction pathway within the heart then, you start off with the Sinoatrial Node here, which is this specialized cluster of cardiomyocytes up in the right atrium, in the wall of the right atrium, that generate the electrical signal. They pass it on to the surrounding cardiomyocytes, which are contraction cardiomyocytes. And contraction cardiomyocytes can conduct the electrical signal. They're just not specialized for conduction. Their main role is contraction. They pass it on to their neighbors, and the electrical signal gradually spreads down the wall of the two atria here. And when the contraction cardiomyocytes receive the electrical signal, they contract, so you get contraction of the wall of the atria that spreads from the top down to the bottom. Okay, there is then this Interventricular Septum which prevents the electrical signal just passing straight onto the ventricles beneath it. This is to prevent the ventricles from contracting top down. Okay, so far we've had the atrial contraction and we've pushed the blood into the ventricles. What now has to happen is the electrical signal has to pass through the through the Interventricular Septum via this little window in the atrioventricular septum known as the atrioventricular node. Okay, so the electrical signal passes through the atrioventricular node, which is a specialized cluster of conduction cardiomyocytes. These pass the electrical signal then onto a network or a bundle of conduction cardiomyocytes known as the bundle of His. These are insulated from the surrounding contraction cardiomyocytes. So the electrical signal propagates down the bundle of His, then down the two bundle branches, the right bundle branch and the left bundle branch, still insulated from the surrounding contraction cardiomyocytes. And then finally you have little conduction cardiomyocyte fibers coming off the sides of the bundle branches, which will then deliver the electrical signal to contraction cardiomyocytes, and the electrical signal will propagate up the contraction cardiomyocytes from the bottom to the top. Okay, and when the electrical signal arrives at a contraction cardiomyocyte, it will contract, and therefore you'll get ventricular contraction spreading from the bottom to the top to eject blood out into the pulmonary trunk and the aorta respectively. So there's just a little reminder of cardiac physiology. Now, in cardiac sarcoidosis, what can happen is you can get granulomas forming in the wall of the heart, okay, and this could damage this conduction system. And if you get damage to that conduction system, then the way that the electrical signal propagates through the heart can go hugely wrong. And when there is problems with the electrical signaling in the heart, that is known as an arrhythmia, and this can cause huge problems because the electrical signals propagating through the heart is what makes your heart beat, and your heart beating is essential for you to pump blood around your body. So if there's problems with the electrical signaling in the heart, this can be a very, very serious problem. So arrhythmias are very, very serious problems, and they can result because of cardiac sarcoidosis, because of these granulomas forming in the muscle of the heart. Okay, the other consequence that you can get from cardiac sarcoidosis is it can cause heart failure. You see, when you get granulomas forming in the wall of the heart, so let me just draw one of these. So let's imagine we've got a granuloma forming in the wall of the heart there. Can you imagine that if you get a lot of those forming, then just like in the case of the lung, where we had lung tissue being lost and replaced by granulomas. Here we're getting heart tissue lost and replaced by granulomas. Granulomas are not capable of contracting the way that heart tissue is capable of contracting. So if you get a lot of cardiac granulomas forming, this might actually lead to the heart no longer actually being able to perform its function properly. It might not actually be able to generate enough contractile force to eject blood out of the chambers properly. And when the heart is now too weak to actually pump blood around the body properly, that's what we call heart failure. The heart is failing to do its job properly. It's failing the rest of the body. So both of these terrifying consequences can result because of granulomas forming in the heart, known as cardiac sarcoidosis. Thankfully, this isn't as common as some of the other places where granulomas can form in sarcoidosis, and it only occurs to 5% of people suffering from sarcoidosis. Okay, so those are the four major sites that I want to discuss where granulomas can form in sarcoidosis. You know, they can occur in other places such as the liver, for instance, the spleen, but those are the main four that we've now discussed. The lungs is the absolutely main place that sarcoidosis can form. The eyes and the skin are also quite common, and then I've mentioned the heart because it can have absolutely devastating consequences. Arrhythmias. You only need one granuloma to form in the heart for it to potentially damage the electrical signalling within the heart and then result in an arrhythmia which can be life-threatening. So that's a major consequence of sarcoidosis. Heart failure, that would obviously require a lot more granulomas to form in the heart before you actually developed heart failure due to it. Okay, so we'll have a break here. In the next video, what we'll actually turn our attention to is the pathogenesis of sarcoidosis. Why do these granulomas form?